The other important thing, as I told you, is you need to know how to take history, because nearly 60% of the stations in the lab exam you need to take history. And again, I've seen a lot of people when they in the mark sheet, the examiner mark sheet for the consultation. Okay, so consultation means history. So a lot of people, they have a problem in the history. So I'm sure all of you know how to take history, but what you're doing now is to brush up your knowledge on history taking. Now, history taking is an art. If you want to come to a right diagnosis, you should have the right technique of taking history. Okay, now, there are some things you should not do while you're taking history. Tell me all the things what you should not do while taking history. Assuming symptom. Will you be assuming symptom?
No, I mean when the patient may be telling you about some symptom, and then you will ask like, is it so severe at night, isn't it, or something like that.
That means you're asking a do not. What you're saying is do not ask leading questions.
Yeah.
Okay, do not ask a leading question. That's what it is. Yeah. For example, imagine you ask the patient, you have a chest pain. He says, yes, I got chest pain. Oh, chest pain, is it like a crushing type? That's, yeah. Yeah, that's the leading question. So, will you ask questions like that? No, why not? What's the problem if you ask the patient, is it like a crushing type?
Because they can only give yes or no answers and you waste time.
So, even if it's not a crushing type, he might think, yeah, doctor. He might agree with your word, is what you said. Why? Why does he think the patient agree with you? They think that maybe, you will come to know the diagnosis easily if he agree. So if it's not, he will sometimes he will agree with that. So that means you don't ask such a leading question. So how do you ask a leading question then? How do you ask this question for the test page? Open-ended. How do you ask the open-ended question?
What kind of pain do you have?
What kind of pain is that? Can you please describe? Then patient will describe the pain in his own word. And the way they describe may not always match with their textbook descriptions. For example, imagine you ask a patient, what type of pain is that in your chest? You said, oh, doctor, I feel as if an elephant sitting on my chest. What do you tell him? Don't talk nonsense. Yeah, how can an elephant sit on your chest? What does that mean? Elephant sitting on my chest. Crushing. Yeah, something heavy sitting on his chest and crushing his chest. That's a crushing pain. So that's what it's trying to tell you. Okay, so what is your diagnosis? Elephant sitting on his chest. What is your diagnosis? MI. Yeah, that's where you have crushing type of pain. That's what you get in MI. But in the hospital, you have to write in the notes also. Once you take history, you have to document everything in the notes. What do you write in the notes? Will you write what the patient says? He says elephant sitting on his chest, or will you write that he says he's got a crushing type of chest pain? What do you write? Describe as you always write the patient words. Don't ever write what you interpret this as, because you might interpret as like a crushing pain. Maybe your consultant interpreted differently. Some other doctor interpreted differently. So you should always write the patient words. Never ever write what you thought it is. Okay, because different doctors will interpret it differently. Okay, that's very important. But anyway, that's only for the hospital because we are talking on the exam here. Exam you are not writing. Now, imagine you ask a patient what kind of pain it is, and he says, oh, doctor, I don't know how to describe it. Then what do you do? Then you give the options. You give different options. So give me the options. Just think. Stabbing. Oh yeah. Well, if you say, oh yes, doctor, stabbing. What's the diagnosis? Early dissection, starving. Sorry? First of all, don't give such an option, which you yourself don't know what the diagnosis is. He agrees. You understand? If you give an option, if he agrees with that, you should be able to think of a diagnosis. If you don't even know what the type of it is, what is the point he gives that option? Okay, sir. Stabbing pain could be like a pericarditis or something, or a pleuritic pain. But yeah, imagine he says, I feel as if a burning fluid. Okay, you have option. You have to give the option. Is it like a burning fluid coming in your middle of your chest, or you feel as if it's a crushing? Okay, so burning fluid, you know what's the diagnosis, right? And the crushing, you know, am I? Or do you think it's a tearing type? Tearing. What is that? That is dissection. Okay, so or does the pain get worse when you cough or when you take a deep breath? That is pleuritic type of chest pain. That is pleuritic type. Yeah, maybe P or pneumonia. Okay, so this is the type of pain. You give options, then he might choose similar to the type of pain what he has got. Then with that, he can think of a diagnosis. Okay, so that means what you said is do not ask a leading question. What I said, okay, don't ask a leading question. But I'm not saying that you do not ask leading questions at all. Sometimes you have to, in fact, actually, you have to ask leading questions. You must ask leading questions, but not until a time comes. Now, until a particular time comes, do not ask leading questions. And I'll tell you later when the time comes to ask leading questions. Okay, you must ask leading questions, but not until a particular time. That I'll tell you later when actually the particular time comes. Okay, now tell me, what are the other things you should not do while taking history?
Not give advice. Don't advise them. Don't believe.
Don't advise while taking history. It means you're telling him don't counsel when you're taking history. Yes or no? Wrong. In some stations, you may have to take history at the same time you'll have to counsel. For example, question says there's a lady, elderly lady being diagnosed to be having osteoporosis. Okay, talk to her about this condition. What do you talk about? Will you take history here?
Yes.
For what?
But she's been diagnosed.
It's already been diagnosed osteoporosis. So what history?
Fractures. Fractures of water.
What for?
She has one because you want to know her risk for future.
Okay, if she did not have a fracture, so she will not.
Then you can counsel about precautions to take, shower mats. And
Okay, what else?
Maybe like medication.
Just answer my question. Will you take history? Yes or no?
Yes.
What for? Risk factors. Yeah, risk factors. And so that if there is a risk factor, she will at least stop that risk factor, if possible. Okay, for example, if she is a smoker, is that a risk factor for osteoporosis? Yes. Do you want to advise her? Yes. So that means you ask, do you smoke? If the patient says, you must immediately counsel at the same time. Okay. So that means some stations you take history at the same time you counsel. Okay, so, but sometimes you only take history, don't counsel at the same time, which I told yesterday, acute condition where you have to come to a diagnosis. Where you have to come to a diagnosis in such stations, do not counsel at the time you're taking history. But if the diagnosis has already been given, if you have to take history for risk factors, so that you know that for this is mainly for the treatment part, you're asking the history, you're taking history for the treatment. You're not taking history to come to a diagnosis because the diagnosis has already been given. Okay, so you're going through risk factors. When you're going through risk factors, that means you're taking history. Do you smoke? Do you do an exercise? What type of food you eat? Imagine the patient is the osteoporosis, he has to drink a lot of milk. You need to ask, do you drink milk at all? If she doesn't drink milk, you have to counsel at the same time, you must drink a lot of milk because you need calcium and milk has good calcium. You need to counsel at the same time. Or if the question says there's a patient diagnosed to be having TIA, talk to the patient. What do you talk? Will you take history? For what? Predisposing factor, the risk of TA, so that they will pay if there is a risk, so that they will not get a stroke next time. You're not taking history to come to a diagnosis of TA because that's already been diagnosed. But you still want to know the risk factors. Does the patient smoke? Does it exercise or not? You need to advise all these things. That means when you give the advice, once you take history, complete history, and then give the advice, or at the same time? At the same time, because the diagnosis has already been given anyway. Okay, so but if his question says this patient got chest pain, take history and discuss the management of the patient. Do you need to ask about the smoking? Yes. If the patient smokes, will you advise the patient to stop smoking at the same time? No. Do you understand that? Because there you have to come to a diagnosis. You don't counsel at the same time. Okay, sir. Fine. Tell me what are the things you should not do while taking history then. Do not interrupt the patient. Do not interrupt the patient when the patient is telling a story. Why don't you interrupt? Why do not interrupt the patient? Listening. Because there's a mark for the listening in the exam. That's why.
You might miss out on some important information.
Yeah. You might, if you don't allow the patient to talk, there may be some important information which the patient may give you without you asking. And sometimes you can't even think of such a thing to ask the patient. Maybe some important information he would have given himself. So, and if you stop the patient, then you may miss those important information. So that's why you should not interrupt the patient. But what if the patient is talking nonsense for a long time? Will you interrupt or not interrupt? Then you must interrupt. Otherwise, you are wasting time. Okay, so especially in exam scenarios also, it can happen. If they're talking nonsense for a long time, if you think it's a wasting time, if patient is talking irrelevant stuff, totally irrelevant stuff, then you must interrupt. How will you interrupt? Wait. If anybody has attended the classes before, don't talk. Yeah, allow the others to think. Sorry to interrupt you. Will you tell the patient to sorry to interrupt?
No.
No?
I could bring him back to the previous statement that he said that was important. Like you were telling, for example, when you were telling me that you had a fever, so let's talk about this fever. Ask him more about the question.
Okay. My question, will you answer my question? Will you tell the patient I'm sorry to interrupt? Yeah? So last time somebody told me you politely interrupt. Then I asked, how would you politely interrupt? Then people say, I'm very sorry to interrupt. Is it polite or not? Is it polite? Imagine the patient is telling me something. And you politely interrupt, saying, I'm very sorry to interrupt. Okay? Those of what you're telling is not important for us. We need to know about this. Can you please tell me about this? Now, will the patient remember that you stopped the patient? Will he remember? Yes. The patient remember. Imagine you end up with the wrong diagnosis later. What will the patient think of you?
You interrupted.
See, I wanted to tell him. He didn't even want to listen to me. He wanted to ask his own thing. That's why he couldn't even come to the diagnosis. Will he think of this? Yes or no? It will be there in his mind. So that means you must interrupt the patient without the patient realizing that you interrupted him. How do you do that? The minute you say, I'm sorry to interrupt, he will remember that. You cannot use that word. So how do you interrupt? First of all, when the patient talking, patient may be talking a lot. If you feel that it's irrelevant, totally nonsense, wait for a pause. Wait for a pause. Somewhere the patient will give you a pause. The minute you get that pause, that delivers. So first of all, when the patient is telling you a story, do you think he thinks that is very important that he should tell the doctor? Yes. Whatever he's saying, he thinks is very important to tell the doctor. But you may know that's totally irrelevant, nonsense. But the patient should not know that you're thinking this nonsense. You should still show the patient that whatever he said is very important. So what do you do? Whatever the minute you get a pause, whatever told you before that, you repeat it. Oh, you mean to say this is what happened? Oh, that's really good. You told me about it. That's very important that we should know. But what about this? You change the topic without saying that, I'm sorry to interrupt. Do you understand what I'm saying?
Yes.
Wait for the pause. Whatever he said just before that, repeat it, what the patient told you. Oh, this is what happened. Really, I see. Okay, but what about this? You change the topic. Okay, without telling the patient that I'm sorry to interrupt. Now, imagine there's a patient, 60-year-old man. 60-year-old man got chest pain. You told him, okay, tell me about your chest pain. And he kept talking. Listen to me. Imagine it's chest pain. Tell me about the chest pain. Chest pain, oh, doctor, today morning, I got up at 5 o'clock. Usually get up around 6 o'clock. But today I got up very early. I wanted to do some exercise, everything. Got up very early. I had my, freshened up. I had a shower. And made a breakfast. I made eggs, sandwiches, scrambled egg. I had bacon. Had a very good breakfast early in the morning, 7 o'clock. Then, then I wanted to read some newspaper. I was sitting there, read the newspaper. I watched the TV. Until 8 o'clock, I was watching TV. Then, I wanted to go out. Is he talking relevant stuff? Irrelevant stuff. Irrelevant. So will you stop him?
No, wait for him to.
Wait for him to pause. Imagine he got a pause. So what do you do now?
Then doctor, you couldn't repeat whatever he said. He's like, oh, that's very important that you told me all of that. You couldn't
But
say that in
imagine,
this
okay,
situation.
fine. So you won't interrupt. But imagine you didn't interrupt. Just let him talk. Okay, imagine you continue. Doctor, I read the newspaper until 8 o'clock. Then I had to go out, and I went out. I had to catch the bus. I was running to catch the bus. Suddenly, doctor, I had this severe pain in my chest. So when he was talking all this information before, was it relevant or not relevant?
For him, it was relevant.
For you, was it relevant or not relevant? It was relevant. That means every information what he said was relevant. Why?
Because
Tell
it
me.
led up to the event.
First of all, the events led up to the incident, how it happened. Okay, so what happened? That day he got up early, had a heavy breakfast.
Bacon.
He had a heavy breakfast. Then, later he said, but then he was running to catch a bus. That's the time he got a chest pain. What does that mean? He got a chest pain on exertion. Okay, so heavy meal can precipitate MI. Exertion can precipitate MI. So all the information what he gave was relevant. What I'm trying to explain to you, what I'm trying to tell you is that don't assume the patient is talking nonsense initially. Wait for some time, see whether it's relevant or not. Only when you're sure that this is totally irrelevant stuff, then only interrupt. Don't unnecessarily interrupt, especially in the exam scenarios. So it's very, very rarely they talk nonsense in the exam scenarios. So don't unnecessarily interrupt unless you're sure they're talking nonsense. So very rarely you may have to interrupt the patient in the exam scenario because they also know they don't have much time. They do not usually waste your time in the exam. Okay, fine. So, but as I told you, sometimes you have to interrupt if you're sure that they're talking nonsense, then you have to interrupt. And I told you how to interrupt. Okay, now tell me other things. What are the other things you should not do while taking history? What other things you should not do while taking history? Let me give you an example. Imagine you ask a patient, do you have fever, diarrhea, vomiting, pain in tummy, any chest pain?
You ask once a month.
Yeah, you have so many symptoms. If you have so many symptoms, patient remember probably one of that. You ask 5 symptoms. So he answered only one, other things he did not answer. Maybe even if he had the symptom, some other symptom, because he forgot, he didn't tell you, he missed the diagnosis. That means how many questions you ask at a time? Only one symptom at a time. So you should ask only one question at a time. Patient has to answer to that, then only ask the next question. Okay. What else you should not do while taking history? For example, imagine you ask a patient, patient got severe chest pain. Ask, do you smoke? Yes, doctor. How much you smoke? Doctor, I used to smoke 30 cigarettes a day for the last 30 years. What else you expect to that? Huh? Right or wrong?
Wrong.
Wrong. That means what I'm trying to don't be judgmental. Don't be judgmental. I wouldn't show any expression. So judgmental type of expressions. Don't even realize oh, yeah, you should not be judgmental. Okay, don't make any such comments, neither use any such expressions on your face. So how your facial expression should be when you're taking history?
Understanding.
Somebody told me mask face.
No.
Yes or no?
No.
Don't have, if you have mask face in the exam, consider that it failed. So no mask face. You must have expressions. What type of expressions? Interesting. Yeah, you should show that you're really interested in listening. That's the expression what you should have. Okay, so show that you're really interested in listening. That's the expression you should have. But don't show unnecessarily too much interest. Especially when do you think people are very interested in hearing? Which type of history? Sexual history. Yeah, but many people say, oh, how many times? Don't show unnecessary interest. Okay, so don't be non-judgmental. I told all this in that means we discussed so many things. What you should not do while taking history. Now let's see what to do. How to take history. How you start taking history. Imagine the question says that a situation man came to the hospital complaining of chest pain. Yeah, Mr. Smith came to the hospital complaining of chest pain. How do you start taking history? How do you start talking to the patient? Talk to me. I'm Mr. Smith. Question says, Mr. Smith, 6-year-old man, came to the hospital complaining of chest pain. Take history, examine and discuss the matter with the patient. I want you to start talking to me.
Okay. Me? Hello, Mr. Smith. My name is Dr. Maz. I'm a junior doctor here in the A&E department.
Stop. What mistake did he already do?
First name with the doctor.
When you say hello, Mr. Smith, what do you do? Wait for the patient to respond. If you simply say hello, Mr. Smith, I'm Dr. So and so, what happened? Probably he's not even Mr. Smith. Yeah, okay, so you don't even know, you did not check the identity. If you say hello, Mr. Smith, if he says hello back to you, what does that mean? That means he is Mr. Smith. You understand?
Yeah.
When you say hello, Mr. Smith, whenever you call the patient, wait for the pause or give a pause so the patient responds. Okay, do it again.
Hello, Mr. Smith.
Hello.
My name is Dr. Maz. I'm a junior doctor here in the A&E department.
Oh, you're the doctor.
Yes. What brings you to see us today?
What brings?
What brings you to see us today?
Okay. What brings us to the hospital? Last time somebody asked, what brought you to the hospital? Patient said, no, doctor, the ambulance brought me. So please do not ask what brought you to the hospital. And also last time people asked, why are you here? Right or wrong? Wrong. Why wrong?
Because obviously you're ill.
It is just like asking a guest who came to your house and you didn't like the guest coming to your house. Why did he come? Yeah, don't ever ask me, why are you here? These are very rude way of asking patients. So how do you ask? Okay, yeah, there are two questions. Either you say, how can I help you? Or can you please tell me what brings you to the hospital? Don't use the word brought you, what brings you. Can you please tell me what brings you to the hospital? Mr. Smith, use the word. Yeah, use his name. The more times you call the patient name, the better rapport you're developing with the patient. Can you please tell me what brings hospital, Mr. Smith? Or how can he help you, Mr. Smith? So this is how you start taking history. That means you're starting an open question. But the question, in the question is already written, he's got a chest pain. Why can't you ask, okay, you said you got a chest pain. Tell me about your chest pain. Why can't you do that?
Might be some extra things that weren't mentioned.
Okay, let's go back to the real life. In the hospital, when you work in the hospital, will you know the symptoms of the patient before you talk to the patient? Who said yes? Oh,
Referral or
ED, not always a referral comes. Patient come directly without any referral.
yeah, but that's why it's not always. So it depends on where the patient is. Or
Sometimes. Who sees a patient first in the A&E department? Nope. Which nurse? Triage nurse. The triage nurse sees a patient in the A&E department before a doctor sees the patient. What's the job of a triage nurse? It's to triage. Triage means prioritize. It's not like a first come first serve basis in any department. Yeah, because there are so many patients keep coming. The doctor has to see the patient one by one. Okay, you can't see all the patients together because so many patients keep coming. And as I told you, it's not first come first serve. Means imagine the patient came, the patient got pain in his elbow. He's waiting to see the patient. Okay, so see the doctor. Now imagine the next is his turn is next. Okay, oh, now my next time is wait, get up. And then another 60-year-old man comes with chest pain. Who has to be seen first? Chest pain. And the nurse took him in. The doctor said, oh, okay. Then the next is turning in. Now he gets okay, my turn. Then another person came with the lady, the 30 lady, severe headache. Who has to be seen first? That headache. And again, that little is still waiting. This is her job, to prioritize who has to be seen first by the doctor. The triage nurse will see the patient, all the patients come in any department. She'll take a brief history. She'll write in the patient's notes what the patient came in. For example, imagine she saw 3 patients now. She will see 3 patients, which one is the priority? Okay, this one, okay, this is the first priority, this is the next one, this is the next one. She will arrange in that order. So now, then she will go to the A&E department. There's a slot where she has the patient cards. Now, imagine there are 10 A&E doctors seeing patients. The next doctor who is free, he has to come and pick up which one? The first one, the first one, because that's the first priority which the nurse has decided. You need to take the first one. Okay, so that's how the nurses prioritize. Now that means this triage nurse has already written a brief notes in her notes. That means when you pick up the patient card, it's already there the patient symptom, what he came in. That means when you go to the patient, you already know the symptom. Will you ask the patient, okay, you told the nurse that you got the chest pain, tell me about your chest pain? Why not? Because nurse does not know how to take history. Okay, she's a nurse, she's not a doctor. Okay, so maybe the main symptom what he came in may not be the one what she asked. What she asked. So that means you should not. What if the consultant taken a history? Will you trust the consultant history?
Yes.
No, you don't trust anyone else's history other than your own history. So that means you should still ask an open question. Forget what is written in the notes. Just ask the patient, open question, how can I help you? Or can you please tell me what brings to the hospital? That means in the exam, the symptoms are already written in the question. You don't name the symptom and ask, okay, tell me about this symptom you had. Okay, forget the symptom, you ask an open question. How can I help you, please? And or what brings to the hospital? Then the patient will tell his whole story. Most of the time, he will tell the same symptom what is written in the question. But sometimes they may start telling some other symptom which is not there in the question. This is what happened last time. Question said the patient got a cough. Patient got a cough. That is what is written in the question. When the people ask, how can I help you? He said, doctor, I'm feeling short of breath. And people got confused. In the question is written cough. Now he's talking shortness of breath. What does that mean?
You should focus on shortness of breath.
That means this patient may be having both the symptoms. He started telling his symptom. The first is shortness of breath, but definitely he has got a cough also because that's what is given in the question. He has got both the symptoms, this one and that one. But he started his story with the other symptom what he's got. It doesn't matter. Okay, so You all started the open question as a children. So how can I help you, or what brings hospital? Then the patient will tell you symptoms. Now, when the patient tells you the symptoms, imagine the patient, oh doctor, I got chest pain. What do you do? What do you do? Chest pain. What about, where is the pain? Since when? Right or wrong? Wrong. What do you do? You ask another open question. Can you please tell me more about it? Okay, so don't ask where's the pain, when it started. Okay, so you should allow the patient to tell the story as much as possible on his own. Let him tell the story on his own so that you don't miss any important things what he wants to tell you. So always ask open questions as much as possible. Can you tell me more about your chest pain? You can do that, of course. That if you don't have to show sympathy, empathy, every symptom. If he says severe chest pain, yes. If he says, oh, I can't bear my chest pain, I'm so sorry to hear that. If he says chest pain can be mild also. If it's pneumonia, it could be mild chest pain. Should you show sympathy, empathy for that? No. Some people have got a sympathy, empathy. They show sympathy, empathy for everything. Okay, doctor, I've been having fever for the last 2 days. Oh, I'm so sorry to hear that. Should you show sympathy for that also? No. Sympathy is the issue when the patients are in real distress, not for every symptom. Okay, so now as I told you, keep asking open questions as much as possible. Now, one important thing I would not, the questions, if the question says you take history, examine, and discuss the management, which one is most difficult for you, history or examination or management? History is more difficult. Why? Sorry? They can change the other two. That's why it is the history is difficult. Because once you know you've got a problem in the chest, examination of the chest or respiratory system or RS, the respiratory system or a CVS examination, is it difficult? No. Once you know the diagnosis, talking to management, is it difficult? No. That means the most difficult thing is to come to a diagnosis. For that, you have to take history. So taking history is very difficult because you need to come to a proper diagnosis. If you miss something here and there, then you can't come to the right diagnosis. That is the most difficult part, is to take history. And also, I have seen in the mock test here, people, I was acting like a patient in the mock test. There, people ask me, they ask me one question, patient says, okay, I got this symptom. What else? Like what? No, you must be having some other symptoms. I said, you ask me, I will tell you. No, you must be having some other symptom. Tell me any other symptom, anything else you have. People keep asking only one question, anything else, anything else, anything else. Why? Because they don't know what else to ask. People forget. People can't remember what to ask. The most difficult thing in the history is they don't know what to ask. After 1 minute, people stuck. Yeah, I've seen here in the people in the mock test, afterward, anything else, after that, they just put their head down. What to ask? What to ask? Can't remember. Can it happen? So what do you do? What do you do in the exam? Imagine after 1 minute, you don't know what to ask, completely forgot. What do you do?
Go to the normal way of tracking.
Normal way of tracking. What is the normal way of tracking?
For presenting complaints, history of presenting complaints, you will have the other systemic.
Good. That's the reason we made it mnemonic. Because it will at least help you to think of what to ask when you're stuck. Okay, so that's the P3 or a P7 in math tools. So we made a mnemonic here. P3 or P7 math tools. That is present history, the past history, personal history, then the other 4 P's. The other 4 P's are for a female of a childbearing age group. That's a period, pregnancy, pills, pap smear. So these 4 P's are for a female of a childbearing age group. Then the maftosa, that's medications, allergy, family history, travel history, occupation, social history. In the last day, I will tell you later what exactly it is. There's a P3 or a P7 maftosa. P7 maftosa is for a female of a childbearing age group. For all other patients, for males or a female who is not of a childbearing age group, the mnemonic is P3 maftosa. So there are some other mnemonic for present history. For present history is like Odipara. Odipara, that is onset, duration, intensity, progression, aggravating and relieving factors. Aggravating and relieving factors. And associated symptoms. Associated symptoms. That's ODPAP. That's onset, duration, intensity, progression, aggravating relieving factors, and associated symptoms. Now there is one more mnemonic for pain, which all of you know. What is the mnemonic for pain? Socrates. Socrates, that is site onset character, radiation, associate symptoms, timing, exacerbating and relieving factors. Exacerbating and relieving factors. And severity of the pain. Severity of the pain. That is Socrates. Site onset character, radiation. Associating timing, exacerbating relieving factors, and severity. Now the mnemonic for pain is Socrates. The mnemonic for all of the symptoms. The mnemonic for all the symptoms other than the pain is Odipara. The mnemonic for all the symptoms other than the pain is Odipara. Now you must understand the importance of all these. You should understand the meaning of all these. Odipara, what is it? And what is the importance of it? For example, onset. What is the meaning of onset? How did it start? When did it start? Yeah, when did it start or how did it start? For example, imagine this is a 30-year-old man. 30-year-old man has got headache. 30-year-old man got headache. You ask him, headache, how did he get this headache? And he says, doctor, few hours ago I was playing football. I fell down and I hit my head on the ground. And since then, I'm having this headache, doctor. What do you think is the diagnosis? Intracranial bleeding due to trauma. Intracranial bleeding due to trauma. That's what you think the diagnosis is. Maybe. Imagine this 30-year-old man who got headache. You ask him, how do you get this headache? He said, doctor, I don't know how I got this headache. I was just in my office and working on my computer. And suddenly I started having this severe headache, doctor. Diagnosis. That is SH. There's a spontaneous bleeding because of very ruptured aneurysm, subacute hemorrhage. So that means, will an onset give a clue to your diagnosis? Yes. Or imagine this is a 55-year-old man who got chest pain. You ask him, how did he get this chest pain? Doctor, I was just running to catch a bus. And suddenly started having this chest pain. And after about 15 minutes, just went away. I'm fine now. Diagnosis, stable angina. Or you're asking me, how did you get this chest pain? Doctor, I don't know how I got this chest pain. I was just sitting there on the sofa watching a television. And suddenly I had this chest pain, doctor. And it's almost 2 hours now. I'm still having this chest pain. Diagnosis. That is ACS. Okay, that is acute coronary syndrome. So that means that the onset itself can give you a clue to your diagnosis. Then the duration, acute conditions, chronic conditions. For example, imagine the patient's got a diarrhea for 3 weeks. Will he even diagnose viral diarrhea? No, because if it's not diarrhea, it will not last that long. So that duration also helps in coming to a diagnosis. And intensity. The intensity or the severity of the pain is almost similar. Let me talk about the severity of the pain first. Severity of the pain. Imagine somebody's got headache. How do you ask about the severity of the headache? How do you ask for it? In the scale of in the scale of 1 to 10, how severe is the headache, your pain is? And I said, doctor, 1 out of 10. Then you must say, what is 1 and what is 10? What is 1? Minimal pain. And 10, the most severe pain. The 1 being the mildest pain, and the 10 being the most severe pain. How do you rate your pain? Yeah, in the scale of 1 to 10, 1 being the mildest pain, 10 being the most severe pain. How do you rate your pain? Imagine the patient told you, doctor, 10 out of 10. Headache. What's your diagnosis? SH. So that means the severity itself can give a clue to your diagnosis. That's about the pain, but here we are talking the intensity. Intensity, as I told you, is for all the symptoms other than the pain. For example, if it is diarrhea, what is the intensity? How frequent? Or vomiting, how frequent? If it's fever, how high? Yeah, these are all intensity. Then is the progression. What do you mean progression? How is it since the time it started? Is it getting better? Is it getting worse? Is it getting all the same? That's the progression. Not only that, is the symptom there all the time, or does it come and go, come and go? Is it intermittent? Will that give you a clue to your diagnosis? Yeah. Now, I'm going to tell you something. You should tell me what symptom I'm talking about and what you think is a diagnosis. Imagine this patient got this symptom for the last 10 days. And the first 2 days he had this symptom. The 3rd day he did not have the symptom. The 4th and 5th day he had the symptom. The 6th day he did not have the symptom. 7th and 8th day he had the symptom. The 9th day he did not have the symptom. And today the symptom, today the 10th day he has got the symptom. Which symptom I'm talking about? What's the type? Fever. Diagnosis? Malaria. So intermittent fever, malaria. So that means the progression can give a clue to your diagnosis. Or imagine this patient got this symptom for a few minutes. The next few minutes is completely fine. Next few minutes again he has this symptom, but the next few minutes again is fine. Next few minutes again he has this symptom, next few minutes is fine. Which symptom I'm talking about? What's the diagnosis?
Fever.
Swinging for a few minutes. Within minutes it will go up and down.
Episodic headache,
Colicky abdominal pain. It's an intermittent pain. Diagnosis. Renal colic, intestinal obstruction, biliary colic. Renal colic, biliary colic, intestinal obstruction. You have narrowed down your differentials to only few things when it is intermittent pain. Okay, so that's why even the progression can help you to come to a diagnosis. That's progression. Then aggravating risk factors, will that give any clue to diagnosis?
Yes.
For example, somebody got upper abdominal pain. You ask him, when do you get this pain in your tummy? And he says, doctor, the minute I eat something, I get severe pain in my tummy, doctor. Gastric ulcer. Or you ask him, what do you do when you get this pain to relieve the pain? Doctor, I have to eat something. Now I feel better. Didn't answer. Okay, so again, the healing factor itself can give a clue to a diagnosis sometimes. The association terms will come to that later. Now let's go to the other side, the pain. The first is site of the pain, site of pain. Imagine the patient told you, doctor, I got pain in my chest. I got pain in my chest. Did he tell you the site? Huh? Chest pain? Chest is a big area. The whole area is chest. So that means you should ask specifically where exactly in your chest.
Can you point it out?
Point it out. Imagine he's got, my chest pain is here. Is it cardiac? No. My chest pain is here. Can it be cardiac? It can be. It's my chest pain is here. Can it be cardiac? Yes. So you know that you can get some clue with the site what may be the condition. Or imagine it says, I got pain in my tummy. Did he tell you the site? No. Why? Tummy is a very big area. Abdomen is a very big area. So what? Yeah, where exactly? Now we have divided the abdomen into 9 regions. Why?
So we can localize.
To
Different organs are.
narrow down the differentials. Because abdominal pain, we have hundreds of differentials. You can't think of every differential if it is tummy pain. So to narrow down the differentials, we have divided the abdomen into 9 regions. Okay, so for example, we have a right hypochondrium, epigastrium, left hypochondrium, right lumbar, the umbilical, left lumbar, right iliac fossa, suprapubic, and left iliac fossa. So all the 9 regions we divided so that we can narrow down the differential. So imagine the ask the patient, where is the pain? Tummy. Where exactly in your tummy? Oh, here. What do you do now? It is still covering a lot of areas. So what do you do? Point out with one finger. Where exactly? How do you say that? Point out with one finger where it hurts you the most. Here, doctor. Will that help you?
Yes.
Yes. So that is a site. Yeah, you should know how to point it. Can you tell me where exactly? Now, last time, this is what happened in one of the chap. Actually, he came from Pakistan. He came here just 10 days before the exam. Usually, I told you, I tell people to come 5-6 weeks before the exam, but not everybody can come. The exam, he couldn't attend the course for a year. So his friend who had already had his exam, he passed the exam. He was teaching him. His friend was teaching him. So he told him, in the exam, if you get a young, beautiful lady with the pain abdomen, diagnosis ectopic pregnancy. And he went to the exam. He had this beautiful lady, pain abdomen. He also gave the ectopic pregnancy. Then he failed the stage. So why?
It could be anything.
Like, because young lady, when you ask where the pain, she said here. Here is ectopic pregnancy. Diagnosis. Right or no? Can we be a scientist? Yeah. So what is the most important question you should ask? One is LMP, which you forgot. Okay, but other one, what is else you need to ask for appendicitis? Rebound. Can you ask the patient, do you have a rebound tenderness? When the pain started, where was it? She said, doctor, it was here. Now it is here. Okay, so this is shifting pain. That means you very important to find out when the pain started, where was it? Understood? So that will give you a clue to your diagnosis. Okay, the site, then the onset, the pain, I told you already, gave the example, character, whatever, we already discussed that. Radiation. This is what happened again. Last time, there's a lady who had a chest pain. 60-year-old man, chest pain, first diagnosis. Am I? 35-year-old lady, chest pain, first diagnosis. 35-year-old lady, chest pain, first diagnosis. First diagnosis. PE, pulmonary embolism. Young lady, chest pain, first diagnosis always pulmonary embolism. Okay, so now this is what happened. Lady, she 35 lady, she had chest pain. Was a doctor, he gave the diagnosis pulmonary embolism. He failed the station and gave my student doctor, man, gave the diagnosis pulmonary embolism, and I failed. Diagnosis was wrong. I said, maybe the diagnosis may not be wrong. Maybe. Can he fail the station even if the diagnosis is right? Yes. Why? If he did not go through the other differentials. I told him maybe he did not ask other differential. He said, no, he went through all the differential. So then I asked him, did you rule out MI? Is it important to rule out MI in 35 lady? Yes. Did you rule out MI? He said, yes, I ruled out. How did you rule out MI? How do you rule out MI? How do you rule out MI? Radiation. I asked him, did you ask about the radiation? He said, yes. How did you ask? He said, I asked her, does the pain go anywhere else? And she said, no. So that's why I ruled out MI. I said, no, you did not rule out MI. How do you rule out MI? First, you ask the open question. Does the pain go anywhere else? Because the pain, she said, is here. Does the pain go anywhere else? She said, no. What's the next question? Does the, show, where exactly? Does the pain go to your left arm or left jaw at all? If she said no, that's when you rule out MI. You understand? There's an examiner sitting there. He should know what you're trying to rule out. If you ask the patient, does the pain go to your left arm and left jaw? Does the examiner know what you're trying to rule out?
Yes.
Yes. That's what you should do. You should ask a specific question to rule out a specific condition. So you should name properly where it is going. Okay, does it go to left arm and left jaw? When the lady says no, that's when you wrote MI. If you simply ask a patient, does the pain go anywhere else at all? If the patient says no, you did not wrote MI. Okay, then I asked him, did you wrote aortic dissection? He said yes. How? How did you ask her this? He said, I asked her, does the pain go anywhere else? She said no, so I wrote out the aortic dissection. I said no, you did not wrote aortic dissection. So how do you write? Does the pain go to your back? When the lady says no, that's when you rule out aortic dissection. That means you should ask specific questions, specific areas where the radius, name it and ask. Yeah, so to rule out a particular condition. Or again, don't miss last. This is what happened last thing. There is a station out of back pain. In the new exam, we have a station for back pain. For the back pain, we get the diagnosis perhaps this. Okay, so perhaps this is the diagnosis. The back pain, where is the back pain? He showed here, doctor here. Imagine the patient, the back pain here. Do you need to ask about the radiation? Yeah, how do you ask? Does the pain go anywhere? Open question first. Does the pain go anywhere else at all? No. For next. Does the pain go to your back of your legs? Yeah. So if the patient says yes, that is sciatic. If the patient says no, probably you ruled out that. Now, what we said here in the class is, if there's a back pain, the diagnosis is prolapsed disc. The last time also one of the chap, we gave the diagnosis of prolapsed disc and failed. I know why. Don't tell me back pain. You said in the class it is prolapsed disc, and again prolapsed disc failed. And asked, yeah, okay. And asked him, okay, where is the back pain? The patient said the back pain is here, and the pain goes here. This is prolapsed disc for you. Not thinking. What can I do? Okay, not all the back pain is prolapsed disc. Yeah, so if the pain is coming from here, what is this diagnosis? It's related to calculus. You're not even thinking properly. What can I do? Okay, so radiation is very important. Now imagine the patient got a pain here. Anywhere else? Doctor got a pain here also. Is it radiation? This is referred pain. This is not radiation, this is referred pain. So what is the difference between radiation and a referred pain? Continuity. In a radiation, the pain is continuous. If it's just pain, the pain is going like this. This is a continuity. Okay, so whereas referred, there's a pain here, there's a pain here, there's no continuity. Okay, that's referred pain. Why there's a referred pain? Because in the same dermatome, nerve supply the same dermatome, that's why. So what is the diagnosis here? Cholecystitis. What's the cholecystitis? So remember, sometimes radiation, R stands for radiation as well as referred pain. Sometimes you may need to ask for the referred pain. Okay, so imagine the 30-year-old lady, 30 lady headache, first diagnosis. Essay. Okay. You ask the lady, where's the headache? Doctor, here. Diagnosis. It is bang like headache. So the diagnosis is tension headache. Do you want to ask her, when the pain started, where was it? Do you like to ask that? Yes or no?
Yes.
Yes or no? Yes. Ask me. Ask me.
When is your when the pain started and what you're doing at that time?
When the pain, where was it when the pain started? Doctor, when the pain started, it was here. Now it's here. Diagnosis. Tension headache. Tension headache? No, this is SH. So that's the reason what I said. Site is very important. Is when the pain started, where was it? Very, very important question. Why? What is the headache here? Occipital headache. Subacute hemorrhage. Why the pain is the subacute hemorrhage is occipital at the back? Why? Because the very symptoms are at the back of the head. When it ruptures, the headache will be initially there. But then when the pressure increases, intracranial pressure increases, the headache will be all over the head. When the patient showing this, don't think this is band-like headache. She is trying to show the headache is all over my head. Okay, so that means the site again is very important, as I told you. When the pain started, where was that? So that will give a clue to your diagnosis. Be very careful in the exams. Okay, so referred, we covered site, we covered, then associated symptoms, we can discuss later. Timing. What is the timing of the pain? Timing. When you get this pain, for example, or any symptom, timing is any symptom. When you get the symptom, for example, young lady, it's a 25 lady, she vomiting early in the morning. Diagnosis? Pregnancy. Yeah. Young man, 25-year-old man, vomiting early in the morning. Pregnancy? Face occupancy. That is a brain tumor. Yeah, early morning symptoms, headache, early morning headache, or early morning vomiting. Young man, your first diagnosis always SYL, space occupancy lesion. So this is timing. What time? Or for example, imagine this patient got fever for the last 15 days. When do you get this fever? Doctor, the daytime I'm completely fine. When I go home after my job, in the evening, I start having sweating. I start having high temperature. Diagnosis. TB. Yeah, that's a nice face. Evening, rise of temperature. So these are all timing. Sometimes the timing could be particular season. Doctor, during this season, I have this problem. So that the timing could be either the time or the day or time of the year. It could be time of the season. It could be anything. Exacerbation, we know severity, we know that. So you understand the importance of all these things now. The OD para and the pain. Now, imagine there's a patient, a 35-year-old man. 35-year-old man came to the hospital with a fever. He complained of fever. And you ask, okay, you had fever, tell me about a fever. You ask one question. And he told you a lot of things like, imagine he said, I got fever for the last 5 days. Last 5 days, I've been having fever. Then ask him, when do you get this fever? Is it throughout the day? Or when exactly you get the fever? He says, throughout the day and night. Yeah, I have this continuous fever. Okay, so, and every day has got a fever. It is not intermittent fever. Continuously, every day has got fever. Morning, evening, every time. And ask him, did you do anything for the fever? Yes, I took paracetamol, but it's not helping. When I take the paracetamol, temperature goes down, but it comes back up again. Okay, so nothing is really aggravating, or nothing is really relieving that. Okay, so intensity, you ask, have you measured the temperature? Yes, sometimes it's about 39 degrees. So he says, yes, sometimes 38, sometimes 39. We've been having that quite high temperature for the last 5 days. So imagine He took history about the fever, the main symptom what he came in. So that's a OD para, what you asked.